Welcome to This Explainer. Today, I'm going to walk you through the very real, very physical realities of chronic kidney disease, specifically from a doctor's perspective. We're going to act as medical detectives for a bit, analyzing the profound structural changes that happen in the heart when the kidneys start to fail. As medical professionals, we're trained to view the body as a set of interconnected systems. But I have to tell you, few relationships are as tightly bound and potentially as fatal as the heart-kidney axis. Okay, so let's dive right into this clinical paradox by asking a question that has frankly puzzled and frustrated doctors for decades. Why exactly do our young dialysis patients face such a massive cardiovascular burden? We're talking about a risk profile here that goes way, way beyond your typical clogged pipes. When you have a 30-something-year-old patient on renal replacement therapy who is suddenly suffering cardiac events typical of someone literally decades older, you have to look beyond standard atherosclerosis. There's a much deeper, far more structural ruin happening here. To find the root of this, we actually have to look backward. This observation from Richard Bright over 170 years ago serves as our very first diagnostic clue. Bright noticed at postmortem that patients with severely shrunken, diseased kidneys consistently presented with massively enlarged, hypertrophied hearts. This early observation confirms that the uremic milieu, that toxic environment created by failing kidneys, triggers profound structural remodeling in the heart muscle itself. It's a systemic reaction, guys, not just a localized cardiac issue. Section 1. The heart-kidney connection, a clinical paradox. Understanding this paradox requires us to entirely rethink how we view cardiovascular risk. We absolutely have to shift our clinical lens away from standard atherosclerosis. Now sure, traditional plaque buildup certainly plays a role in advanced kidney disease, but non-atherosclerotic changes, specifically heart wall thickening and arterial stiffening, are the actual dominant pathologies here. We need to start viewing this as a disease of the heart's fundamental geometry and the arterial system's mechanical compliance, rather than just a plumbing problem of blocked vessels. Section 2. Remodeling the heart's geometry, the mechanical toll. Let's see how this builds when we actually measure a patient's heart structure over the course of their kidney decline. Now, what's really interesting about this data from the CRSX study is the striking stepwise progression. As you know, we track kidney function using the estimated glomerular filtration rate, or eGFR. Well, this chart proves that as kidney filtration drops, left ventricular hypertrophy, or LVH, literally skyrockets. Even in mild kidney disease, nearly a third of patients have abnormal heart thickening. And here's where it gets truly shocking. By the time their eGFR falls below 30, a staggering 75% of these patients have structural heart remodeling. So this proves the heart is adapting to a hostile environment long before the patient ever reaches a dialysis chair. When we look at the gross pathology of a postmortem heart like this one, it brilliantly and terrifyingly illustrates the macroscopic thickening of the ventricular wall. Just look at the sheer mass of that muscle tissue. The heart is desperately adapting to severe pressure overload and hypertension, which of course are direct consequences of the kidneys failing to regulate blood volume and vascular tone. To be clear, this isn't a healthy athlete's heart. This is a strained, overworked organ teetering right on the brink of failure. In the clinic, we differentiate this adaptation mechanically, and that tells us exactly what the patient's body is struggling with. Concentric hypertrophy, that massive inward thickening we just saw, fights against high blood pressure. The muscle cells grow thicker just to distribute all that stress. On the flip side, eccentric hypertrophy happens when the heart dilates and stretches out to accommodate the severe fluid volume overload that failing kidneys can no longer excrete. Now, both of these adaptations initially help maintain cardiac output, sure, but they ultimately set a very dangerous trap. Section 3. Microscopic damage and fibrosis, the hidden starvation. But to truly understand the prognosis here, we have to act like a pathologist and zoom right in on the cellular level. Because what looks like incredibly strong muscle to the naked eye is actually hiding a deadly secret. We call this hidden danger impaired angioadaptation. Normally, if a muscle grows, new blood vessels grow right along with it to supply oxygen. But in chronic kidney disease, that systemic angiogenic response is completely broken. As the cardiac muscle violently thickens, the capillary blood supply completely fails to grow with it. The tragic result is that the very tissue working overtime to keep the patient alive is actively starving for oxygen. And this biopsy slide shows exactly what happens next in that starved environment. The darker red areas are the struggling cardiac myocytes. But notice how they're being choked out and replaced by this pale staining tissue? That is myocardial fibrosis. Essentially, it's scar tissue. When those starved muscle cells inevitably die, they're replaced by this rigid, unyielding matrix. This fibrous tissue severely disrupts the heart's electrical pathways and its physical ability to expand and pump. Moving on to Section 4, calcification and valve disease, the stiffening system. Because the damage isn't just in the heart muscle itself, the entire vascular highway feeding the heart is quite literally turning into rigid bone. We absolutely must distinguish standard patchy atherosclerotic plaques, your classic cholesterol buildup inside the vessel lining, from Monckeberg sclerosis. Monckeberg sclerosis is this devastating linear calcification of the artery's middle layer. It's not driven by high cholesterol. It is directly tied to the abnormal calcium and phosphate metabolism raging inside a kidney patient's body. The artery basically stops being a flexible tube and becomes a rigid lead pipe. This side-by-side brilliantly illustrates our diagnostic journey from the microscope straight to the radiology suite. On the left, the dark staining shows calcium physically embedded deep within the medial layer of the artery wall. And on the right, when we put this patient in a CT scanner, those calcified coronary arteries light up bright white, exactly like bone. This rigid vascular system severely limits blood flow and just drastically amplifies the stress on the already struggling, thickened heart we analyzed earlier. Section 5. Clinical consequences in patients, the final cascade. So, we have to ask ourselves, what does this rigid, starved, and overgrown cardiovascular system actually mean for the patient sitting right there in our exam room? Well, it translates to this single, terrifying number, 5. This represents a 5-fold increase in the annual incidence of sudden cardiac death in the kidney disease population compared to the general public. In the dialysis population, sudden cardiac death accounts for over half of all cardiovascular mortality. This isn't some slow, gradual decline. This is an abrupt, catastrophic electrical and mechanical failure. Let's just trace the fatal clinical cascade we've uncovered today. The kidneys fail, which prompts physical, structural remodeling in the heart. This massive growth leads to capillary starvation. Starvation breeds rigid fibrosis. The fibrosis drastically stiffens the ventricles until catastrophic electrical dysrhythmias occur, causing sudden cardiac death. This chain reaction right here is the timeline we are fighting against every single day in the clinic. Ultimately, a major endpoint of this entire cascade leaves the patient with profound diastolic dysfunction, meaning they have a rigid heart that simply cannot relax to fill with blood properly. Practically speaking, this makes managing these patients incredibly difficult. Because their stiff ventricles are hypersensitive to any volume changes, the routine fluid shifts they experience during regular dialysis treatments become highly dangerous. You're constantly risking severe pulmonary edema or crashing their blood pressure. Since we know for a fact these structural changes begin at the very earliest stages of renal impairment, far, far before a patient ever needs a dialysis machine, the ultimate clinical question we must leave it today is all about prevention. Just how aggressively must we act upstream, addressing blood pressure, calcium, and phosphate balance at the very first sign of kidney trouble to prevent this mechanical ruin? Thank you for joining me on this explainer. I hope it serves as a stark reminder that to truly save the heart, we have to vigorously protect the kidneys.